Namaskar, Happy New Year. So today we are going to discuss about one of the most important weapon what we have today to fight against COVID-19. So today's topic of presentation is ray of hope in management of COVID-19. So we all know about our enemy, but what I just want to focus is in this slide, the target of this particular weapon, which we are going to discuss today, is that spike protein. And we all know monoclonal antibodies are used in different types of disease. And the journey started at around 1986 when we got one monoclonal antibody known as Neuromonab, which was used for graft rejection, specifically used for transplantation patients, kidney transplantation patients, to prevent graft rejection. So this slides clearly shows the interest of non-infectious disease, which was predominantly dominated the fields of different therapeutics pre-2019. But after this COVID-19 pandemic, we can see how the interest, the transitions of interest happen from non-infectious disease to infectious disease. And here you can see the different monoclonal antibodies used in different types of infectious disease. So starting from palivizumab, which was against the respiratory syncytial virus, came into the market of America in around 1998, and then some other monoclonal antibodies are developed specifically against anthrax, rabies, and also some drugs like evolizumab, which was tried for HIV patient. And in 2020, we got anti-Ebola virus monoclonal antibody. But after that COVID-19, the entire focus was considered against the anti-COVID-19 monoclonal antibody developments. So till date, what approved in India against COVID-19, or rather we can say the restricted use authorization, that is the Casirivimab Imdevimab cocktail, monoclonal antibody cocktail. So this is the thing what we had mentioned previously, the spike protein, generally by which it enters the host cell. The monoclonal antibodies like imdevimab or casirivimab, they binds with this receptor binding domain of spike protein and ultimately prevents viral binding or fusion with the host cell. So this is the ACE2 receptor, what we can see. The spike protein generally binds with this ACE2 receptor binding domain and enters into the host cell. So this process is inhibited by this monoclonal antibody. And in this diagram, again, we can see the various types of monoclonal antibodies that we have against COVID-19. Obviously, these vaccines are there. They are not monoclonal antibody, but in this cartoon, we can see how the different types of therapeutics can be applied in different phases of disease. So when we are not ill, when the virus not enter into our body, then there is a role of vaccines. There are different types of vaccines, we all know. Then even before the pre-exposure place, there are some monoclonal antibody which are in trial, and specifically one AZT, we can see that one monoclonal antibody cocktail is used as a pre-exposure prophylaxis. It is now the phase 3 clinical trial is ongoing. We have to check the results of that particular monoclonal antibody. But there are some monoclonal antibody when the exposures already happen, but patient is not symptomatic. So just like what we have in case of rabies, the human rabies immunoglobulin. So same thing, same concept, some post-exposure prophylaxis monoclonal antibodies are now tested, and there are some good results also with some of them. Specifically, we'll little bit discuss about this Casirivimab Imdevimab monoclonal antibody cocktail as a post-exposure prophylactic agent today. So there is the position where we can use this group of drugs as a post-exposure prophylaxis. Then what happened? The early phase. So early phase means the viral phase. So all the antiviral monoclonal antibodies will act here, and we can see the list of drugs like starting from bamlanivimab to etesevimab and bamlanivimab combination, then casirivimab, and very recently this monoclonal antibody known as sotrovimab, which is one monoclonal antibody which got emergency use authorization, and most probably one of the very important weapon that will help us specifically during this emergence of different types of variant of concerns, mutant variants, because this particular monoclonal antibody developed with a historical background when there was a SARS CoV1 epidemic, and in the SARS CoV1, the spike protein, they have some similarity with this SARS CoV2 spike protein, and this particular monoclonal antibody acts against that particular region where there is some similarity between SARS CoV and SARS CoV2. So this is something special where mutation not affected that much, but we need to have more studies to have the final comment. But scientists are thinking that this can be a good answer to different types of mutant variants, sotrovimab. And there are some concepts, the phase 3 clinical trials are ongoing, even in the late phase of disease with Casirivimab Imdevimab combination. But again, what is very important to note that these monoclonal antibodies will act if we use it in the early part of the disease. If the disease progressed from viral phase to inflammatory phase, I think there is no role, or we can say, as the virus is not responsible for the second part of the disease, there is no way to use something which is antiviral. So rather we should consider different types of anti-inflammatory therapy and other conservative management if the patient appears to us lately. So all the antiviral monoclonal antibody, they have their role predominantly in the early phase of the disease, and we should not delay the initiation of the therapy if we are thinking to start. So how does the antibody cocktail work? Antibody cocktail means the Casirivimab and Imdevimab. So Imdevimab blocks the attachment by binding with receptor binding domain of S1 subunit of the spike protein. And there is another non-overlapping portion of that particular receptor binding domain of spike protein that is bound with the Casirivimab. So in this diagram, we can see these antibodies, Casirivimab and Imdevimab. They binds with the specific part of the spike protein, and therefore they will not bind with the ACE2 receptor, which is present in the human host cell, and it will not fused and enter into the human host cell. So they have a synergistic action. They prevents the binding of the SARS CoV2 virus to host cell and leads to restriction in viral entry, and ultimately the replication of virus will not happen. So the question is where and how to use the mAb cocktail. The product is indicated in mild to moderate COVID-19 patient above the age of 12 years. Patient with high risk of developing severe COVID-19 and or requiring hospitalizations are likely to get the benefit most. So we need to also understand who are the high risk patient. And high risk patient means presence of any following risk factors. Number one, age, more than 60 years, more than equal to 60 years. Obesity. Now, the term obesity is a little bit controversial again. How to define obesity if a patient appears to you? So there are different definitions of obesity. So we need to be India specific also. If we are considering Indian context, then any patient whose BMI is more than 23 kg per meter square, we need to be cautious because they are overweight. And if it is more than 25, they are obese. And also, irrespective of body weight, if the abdominal circumference for male, if it is more than 90 centimeter, and in case of female, if it is more than 80 centimeter, they are obese. Apart from obesity, we also should consider patients with cardiovascular disease, including hypertension, chronic lung disease, including asthma, type 1 or type 2 diabetes mellitus, chronic kidney disease patients, including those on dialysis, chronic liver disease patient, or the immunosuppressed patients, like patients on cancer therapy, bone marrow or organ transplantation, HIV patients, sickle cell anemia, thalassemia patient, or some patients who are taking prolonged corticosteroids. So if a patient is taking a drug which weakens his immunity, so those are the patients who can be considered as high risk patient, and we should think to start this Casirivimab Imdevimab combination early after diagnosis. Now I just want to discuss one very important publication that had shown, this is one phase 3 clinical trial where it has been seen that the Casirivimab Imdevimab combination reduced the risk of COVID-19 related hospitalization or death from any cause, and it resolved symptoms and reduced the SARS-CoV-2 viral load more rapidly than the placebo group. So this is why we are considering this molecule in case of high risk COVID-19 patient. So here we can see from this diagram the benefits of this REGEN-COV or Casirivimab Imdevimab combination in terms of reduction of hospitalization or death. There is almost around 70% of decrease in relative risk reduction. So death from any cause, there is also a decrease around 70%. So we can see here the summary of the trial, the result. That is, if the 1200 milligram of those Casirivimab and Imdevimab reduce the hospitalization or death from any cause through day 29. And it has been seen that at the relative risk reduction is almost 70%. Not only that, this benefit we can see irrespective of the viral load. So viral load more than 10 to the power 6 copies per ml, that also shows a benefit. And what is important, the baseline antibody should be negative. Who are serum antibody negative at baseline, they shows at around 75.8% relative risk reduction. And now if we just see the death, the patients with risk factors and COVID-19 related hospitalization death from any cause from day 4 to day 29, there is also a statistically significant reduction in case of 1200 milligram total dose. The relative risk reduction is almost 71.7%. Not only that, the median time of resolution from the COVID-19 symptoms in days, there is a statistically significant faster resolution of around 4 days if we are using this monoclonal antibody cocktail. So this is why we are now telling about this monoclonal antibody cocktail. But one very important point we should remember, as it is a antiviral monoclonal antibody, so the treatment should be given as soon as possible after the detection of COVID-19 and within 10 days of from the symptoms onset. So it is our responsibility to aware our patients, if they have symptoms, they should go for testing. And if it is positive, then they and they are high risk, they should initiate the therapy as early as possible. There is nothing like that we can wait and then we can start, because if we are going to wait, then there is no way to get benefit from this particular infusion. So if we are delaying the initiation, the probable benefit, the intended benefit will be decreased. So this is a very important message, and we are really fortunate that in India this drug is approved from May 2021, and this is available as 600 milligram Casirivimab, and in a bottle, in a package, there is 1200 milligram Casirivimab and 1200 milligram of Imdevimab. We need to give 600 milligram of Casirivimab from that, the half of the thing, and 600 milligram Imdevimab from another package, and we have to mix it and we have to infuse it to the patient. But the thing is that generally it is indicated for the treatment of mild to moderate COVID-19 in high risk patients, as already we had mentioned, and Roche has a partner like Cipla for pan-India distribution of this drug. And I think this is a very good molecule to combat against COVID-19. The intravenous infusion is better, but when there is a question on feasibility, then we should go for the subcutaneous injection also. That has an alternative role. Apart from that, the what is important, already we had discussed, the mAb cocktail is available in a pack of 2 vials. That is, one is Casirivimab 1200 milligram and one is 1200 milligram of Imdevimab. Now, 600 milligram Casirivimab and 600 milligram Imdevimab administered together as a single IV infusion after diluting it with a 250 ml of normal saline. And then we need to give that intravenous infusion over 30 minutes. So this is the way we can use this molecule. Yes, there are a concern on mutations. Specifically, there is not that much study on Omicron variant, but alpha, beta, gamma, and delta variant, it was seen there is no change in vitro susceptibility in case of this Casirivimab plus Imdevimab combination. But in case of, it is very important to note there are some concerns arise with specifically this Omicron variant and effect of this molecule. We need to check more data on that particular portion. But as I had mentioned about Sotrovimab, which is targeting a very specific portion of spike protein, which spike protein is common both SARS-CoV-1 and SARS-CoV-2. So that has, I think, some good potential to target that different types of mutant variants also. So again, we need to get more data on that, but the time will say whether the Casirivimab plus Imdevimab monoclonal antibody cocktail is also good for Omicron variant. What are the different adverse effects? It is generally safe drug. There is a possibility of different types of hypersensitivity reactions like anaphylaxis, to different types of infusion related reactions like fever, chill, nausea, headache, bronchospasm, hypertension, angioedema, throat irritation, urticaria, pruritus, muscle pain, and dizziness. But they are very less, and for that we need to monitor patients for at least 1 hour post IV infusion. So mAb cocktail therapy is not a contraindication also for patients having breakthrough COVID-19. This is also we need to remember. And another important aspect, as already we had discussed a little, the post-exposure prophylaxis. So there is one trial that happened with subcutaneous mAb cocktail with Imdevimab and Casirivimab monoclonal antibody combination, whether they can prevent COVID-19 or not. Yes, they are preventing that. So in both the incidence of symptomatic infection and overall infection reduced a lot. So here we can see the relative risk reduction in terms of symptomatic COVID-19 infection is almost more than 80%. And here we can see the different parameters starting from the duration of the symptomatic infection, duration of any asymptomatic and symptomatic infection. It was quite a good in number, the reduction, the relative risk reduction. And those person who are very much symptomatic, so there the duration of symptoms, that means I am taking the mAb cocktail, but I am getting some symptomatic infection. In that subgroup also, the mean duration of symptoms was much lesser, and mean duration of any asymptomatic and symptomatic infection among all infected participants, in that case also it was a lesser in case of those patients who were taken the Casirivimab Imdevimab combination subcutaneously as a post-exposure prophylaxis measures. So duration of high viral load in each group and mean duration of high viral load among all infected participants, in that also there is a clear-cut benefit. And that is why the FDA came out with a recommendation. So they authorize this Imdevimab, Casirivimab monoclonal antibody therapy for post-exposure prophylaxis for COVID-19. But clearly, they are not a substitute for vaccination against COVID-19. That is very important. They may only be used as post-exposure prophylaxis for adults and pediatric individual. Their level is more than 12 years. As per the label, it is more than 12 years of age and weighing at least 40 kg, who are high risk for progression to severe COVID-19, including hospitalization or death. They should get this as a post-exposure prophylaxis. Who are those people not fully vaccinated, who are not expected to mount an adequate immune response to complete SARS-CoV-2 vaccination, like if a patient is already immunocompromised, like HIV patient, or patients taking some immunosuppressive medications for long duration. So even after having the fully vaccinated, their immune response will not that much uh, expected to mount. So they can be a good candidate to get this, and have been exposed to an individual infected with SARS-CoV-2 consistent with close contact criteria as per the CDC, or who are at high risk of exposure to an individual infected with SARS-CoV-2 because of occurrence of SARS-CoV-2 infection in other individuals in the same institutional setting, like very commonly used in case of nursing homes, where a patient is there for long term. Different types of patients are there in a close contact. One patient becomes COVID-19 positive, so other patients who are at high risk, they can be a suitable candidate to get a post exposure prophylaxis of this monoclonal antibody cocktail. So with that, I just want to thank you all for your listening, so we can take some questions and uh, some comments also from your side. Thank you all. Thank you very much.